Welcome to Cardiology Fellowship. This is, I guess, is this the first lecture you guys are having as new fellows here? I guess it is, huh?
Yeah.
All right. So, can you see my screen that says Arrhythmias in Children, Assessment and Management? Okay. So today's lecture is a general talk on electrophysiology, and please feel free to stop me at any time. Let me just fix this a little bit. There we go. Okay. So one of my mentors, Dr. Jim Locke, used to say that the EKG is a useless test in pediatric cardiology except for diagnosing WPW. I hope to suggest to you that this is one of the rare instances where Dr. Locke was in fact false and not true. So today we're going to just, this is a very general talk, and we're going to basically split arrhythmias up to the bradycardias, which are sometimes viewed as the boring arrhythmias, and then the tachycardias. And when we're talking about a tachycardia, we're talking about disorders of automaticity as well as disorders of reentry. So let's just all get on the same page in regards to the conduction system. So remember that the impulse starts at the sinus node, which is located at the area where the SVC joins the right atrium. And the SA node is actually fairly large. It can be as large as, I think, 15 millimeters or 20 millimeters. It's a pretty large structure. The impulse goes across the atrium, reaches the AV node. The AV node then conducts to the His bundle, and the His bundle then divides into the right and the left bundles. And the right bundle actually has two bundles, but the point is this is the general construct of our normal conduction system, which is something we think about in the electrophysiology world continuously and always. So when I think about arrhythmias of any sort, what I typically do is in my mind's eye, I think about what's going on at the, I work my way from the top of the heart down whenever I'm considering any kind of arrhythmia, and that goes for both tachycardias and bradycardias. So the first thing, the highest portion in the right atrium, obviously, is the sinus node. So sinus node dysfunction would be the first cause of bradyarrhythmias or slow heart rates. Sinus node dysfunction is extremely rare in patients who have a structurally normal heart, but it is commonly seen following congenital heart surgery. In an acute phase, it's not uncommon to see sinus node dysfunction following AV canal repairs or sinus venosus ASD repairs. Sinus venosus ASD repair makes more sense, right? Because the surgeon is literally putting sutures around the area of the sinus node. AV canal repairs, I've never had a very good understanding of why that is, but it's not uncommon that patients following AV canal repair will be slow, at least initially. Chronically, though, the most common things we worry about with sinus node dysfunction are patients who have mustard or Senning repairs for transposition, and then again, Fontan patients or single ventricular hearts. It's a very common problem. And it's not hard to understand why it is that people who've had a mustard operation, and for those of you who may not remember, the mustard operation or the Senning operation was an atrial baffle that was created in an era before surgeons understood how to properly do an arterial switch operation. And so rather than switch the great vessels, they would instead baffle the IVC and the SVC to the left ventricle, which was the subpulmonary chamber, and typically the pulmonary veins would drain behind that baffle to the right ventricle and to the aorta. And you can see that there are literally hundreds of sutures that are put across the atrium, particularly around the SVC. So it wouldn't be shocking that people following this operation would have sinus node dysfunction. And there have been many, many studies looking at this. This is one of the very first ones from basically nearly 40 years ago from Dr. Hayes and Dr. Gerson, both friends of mine, and basically showing on the y-axis is the number of years from the surgery, on the x-axis rather, on the y-axis is the percentage of patients in normal sinus rhythm. And basically what you see is that by about 10 to 15 years out from surgery, essentially nobody was in sinus rhythm in long-term follow-up. And this type of curve could be easily reproduced for patients following the Fontan perhaps with a longer x-axis, but still very, very common that patients would develop sinus node dysfunction when they're having surgery around that area. And this is just an example of the type of Holter or Zio patch or Barty device following sort of tracings that we would see, where patients will just have very long pauses. They actually have preserved conduction, but they will have very long, frequent pauses. And this is a tracing from a paper from 35 years ago, looking at, actually 40 years ago, looking at, 30 years ago, looking at a patient who's 13 years after a mustard and very typically having these long pauses. As I mentioned a moment ago, people who've had the Fontan have a very similar problem. This is a paper from 1998. Looking at, in the y-axis is the percentage of patients who have sinus node dysfunction, and then here's the age of the number of years from the Fontan, and we see that if you're 4 to 7 years out from Fontan, nearly 50% of patients actually have sinus node dysfunction. So it is very common to see this in any kind of surgery where there is surgery around the sinus node. And the interesting thing is that as I've been, up until this point in my career, I was not typically the person who would read all of the Holters or the Zio patches. At Sinai, I have sort of seems to become my job. And I read a lot of Zios for the adult congenital service. And the thing that strikes me always is how frequently we see sinus node dysfunction, even amongst people who are not supposed to have sinus node dysfunction. In fact, I would say it is unusual to see an ACHD Holter in a patient who does not have some form of sinus node dysfunction with very little heart rate variability. And this is important because if you're ever looking at a tracing of an older Fontan patient, let's say over the age of 10 to 12 years of age, pretty much you'll almost never, except during activity, see a sinus rate above 100. So if you're looking at a Fontan patient whose heart rate is 110, the burden of proof is on you to prove that it is in fact sinus rhythm and not something else. And I have seen some very senior cardiologists send patients home from the office for a routine visit in atrial flutter because they didn't recognize this fact. Okay, so moving down in the heart, we're now talking about conduction blocks. And so there are many levels of conduction block. First of all, when patients have sinus node dysfunction, you could have sinus node function with exit block, particularly due to things like scarring in that area. And some people would say that maybe these mustard and setting patients don't actually have sinus node disease. Maybe they just have exit block. It's hard to tell the difference without intracardiac catheters. Then when we go down to the level of the AV node, you can have so-called Mobitz 1 heart blocks. So there's first degree, second degree, and third degree blocks. So in first degree block, the PR interval is long, but all P waves are conducted. In second degree block, there is Mobitz 1 and there's Mobitz 2. Mobitz 1 block is generally thought to be due to an injury at the level of the AV node, not at the His Purkinje system. And there is a continual prolongation in the PR interval until there's a drop beat. In Mobitz 2 second degree heart block, we have P waves that are conducting with a normal PR, and then all of a sudden you'll see non-conducted P wave or two. And sometimes people will call this high-grade block. It's usually due to injury to the His Purkinje system, not to the AV node. There's overlap between the two. There's also a third type of second-degree block, which sometimes people call 2-to-1 heart block, where you have 2 P waves for every QRS. 2-to-1 heart block is either Mobitz 1 or Mobitz 2, but you often can't tell without intracardiac recordings. And so we typically call second degree either Mobitz 1, Mobitz 2, or 2-to-1, with understanding that 2-to-1 is probably either Mobitz 1 or 2. And then finally, in third degree block, no P waves are conducting at all. And you can have either a normal QRS or a narrow QRS, which sometimes people call a junctional escape, or a wide QRS. I'm not really sure why the person who wrote this, made this little diagram, separated those two, but the bottom line is In third degree block, all the P waves, none of the P waves conduct. So again, first degree block, all P waves conduct with a long PR. Third degree block, no P waves conduct with any PR. And second degree, they conduct in different varying manners based on the level of block. Now, there are many, many causes of heart block in kids, and by far, the most important one and the most common one is block due to trauma from cardiac surgery. In pediatrics, by far, the most common reason that we see heart block is people who have had injury to their AV node as a result of heart surgery. Now, there are also, of course, many, many other potential causes. Probably the second most common in our business is viral myocarditis, but many infectious diseases such as Lyme disease, Chagas disease, diphtheria, thankfully we don't see that as much with immunization, endocarditis, all of these can cause block. Multiple inflammatory disorders, particularly rheumatoid arthritis or Guillain-Barré, can cause heart block. We've already talked about trauma from heart surgery. You can also have AV block from blunt chest trauma or from radiation therapy. I've not actually seen that before, but certainly makes sense that that could happen. Certain neurodegenerative disorders like myotonic dystrophy, Kearns-Sayre syndrome, muscular dystrophy can be associated with heart block. A lot of infiltrative disorders like tuberous sclerosis, amyloidosis, lymphoma, or sarcoid can cause heart block. And then there are many pharmacologic agents that can cause heart block, like tricyclic antidepressants, digoxin, particularly if it is overdosed. Multiple antiarrhythmic agents can cause heart block, which is one of the reasons why in postoperative patients we try not to give them in the absence of temporary pacing wires, and then clonidine. So lots of different things can cause heart block, but if you're going to take one thing away from this screen, it should be that heart surgery is the most common cause of block that we see in pediatrics, followed by myocarditis. Okay, so this is an example of a 7-year-old who presents with severe cold symptoms, lethargy, dyspnea, and the echo demonstrates a severe ventricular dysfunction. And what we're basically seeing here is a bunch of P waves that are not conducting, and there is no obvious relationship between the P waves and the QRS. And so this would be most consistent with the diagnosis of complete heart block, presumably due to myocarditis. Whoops. Okay. And now this instead, though, is an 8-year-old who's referred to cardiology for evaluation of a heart murmur. And we see that the PR interval is getting a little longer, and then a little longer and longer still, until finally there's a P wave that does not conduct. This would be an example of Wenckebach or Mobitz 1 heart block. Now, when somebody presents with heart block, we would normally treat the underlying problem. Unfortunately, as we just learned, a lot of the causes don't have underlying treatments, but some of them do. You know, myocarditis, we would use supportive therapy. Endocarditis, we would treat with antibiotics. Some of these inflammatory diseases. So some of these diseases, which are very rare, we would treat, but some we would obviously need to place a pacemaker. And so if someone has a postoperative heart block due to an irreversible cause, we would place a pacemaker. So let me ask, I'll ask my first question of the year, and I'll punt it to Ivana. Ivana, when a person has a postoperative heart block, I'm sure you've noticed, having been a critical care fellow, that by post-op day 8 or 9, we will place a pacemaker. And that's based on data showing that at about day 9, the chances of recovery of conduction is extremely low statistically, almost zero. So my question to you is, let's say you have a patient who had a VSD repaired and they're doing well, and they have a escape rate of, let's say, 70, well perfused. You've been just watching them with a VVI backup of 50, and they never are paced. So why do we put pacemakers in those patients if they have a pretty good escape rate and, you know, seem very well perfused and have a good cardiac output? You are muted. There you go.
Good morning, Dr. Pass. That's a great question that I don't necessarily know the answer to, but I imagine we get a good amount of our cardiac output from the kind of AV concordance, and about 20 or 30%, I believe, from the atrial kick. So over time, I imagine they would develop some component of heart failure.
Well, that's that everything you said is true, but I'm sure you've seen that we've not uncommonly placed VVI pacemakers in people who've had postoperative heart block, and they all seem to be doing very well. Just the other day, about 6 months ago, I had a patient who we put a VVI unit in 10 years ago. He's 16 and his vein was wide open and it was time for a gen change, and I still left him VVI. So, okay, so I'll explain. So the reason that we put pacemakers in people who have postoperative heart block is based on historical data. It turns out that in the past, when you could do this type of study, studies exist in the early 1970s looking at surgical postoperative heart block and what happens to those patients. And it used to be that putting a pacemaker, particularly in a child, was a very, very big deal associated with a lot of erosion and infection and stuff. So you could still do a study where you looked at patients who had a pacemaker in that setting and patients who did not. Turns out that if you look at patients who have postoperative heart block due to surgical trauma, 50% of them die after 1 year, presumably from Stokes-Adams attacks. So now, it's unclear if in the present era, with the way that surgeries are done, would that risk still be just as high? I don't know, but I don't think we believe there's adequate equipoise to do that study any longer. And so basically, pretty much, if you have postoperative heart block, we do not accept the stability of the escape rate as proof that you are safe. And so we would routinely and always put a pacemaker. In olden times, in the early 90s and late 80s, some surgeons were actually even putting transvenous pacemakers in patients, but over time we've abandoned this approach because it causes occlusion of the vein, also a lot of erosion of the device itself. So pretty much in 2023, and probably for the last 30 years, we've been putting mostly epicardial pacemakers in small children who have heart block after surgery. Okay, so that's enough about heart block for this morning. We're going to have lots and lots and lots of tracings all year long of pacemakers and heart block, and we're going to spend a lot of time talking about heart block. But this is a smorgasbord of arrhythmia talk today. So we're now going to move on to the tachycardias. And when I think about tachycardias, I divide them in my mind between disorders of automaticity and disorders of reentry. There is a third form called triggered automaticity, but from a clinical perspective, I think it makes most sense to think about these as either automatic or reentrant arrhythmias. And this is important because it has a very meaningful impact on evaluation and particularly management. So I remind you from medical school that there's calcium channel cells that have a normal action potential and are constantly depolarizing. And these are found predominantly in the SA node and the AV node, and they have the highest degree of automaticity in most human beings' hearts. And the SA node particularly has the highest degree of automaticity. And so when we are in normal rhythm, we're in sinus rhythm because the sinus node is beating fastest. And the rule of the heart and rhythm is that whatever is beating fastest usually controls the rhythm. So what are some common characteristics of automatic arrhythmias? First of all, they typically heat up and cool down. They are not abrupt onset and offset. And this is where having access to the telemetry when you're assessing perioperative or in-hospital patients, arrhythmias is very useful to look and see what does the heart rate trend look like, because the absence or the presence of an abrupt onset and offset can be very, very useful diagnostically. Very importantly, automatic arrhythmias cannot be DC cardioverted. And sometimes the response to DC cardioversion is in fact the best way to tell if something is automatic. And this is one of the reasons why when a patient has an automatic arrhythmia and the patient or has an arrhythmia and is stable and you're going to DC cardiovert the patient, it's always useful to run the 12-lead rhythm strip because the response to DC cardioversion can be very instructive in understanding the mechanism. And then finally, automatic arrhythmias are very catecholamine sensitive. So in settings of high catechols, such as patients on a lot of inotropes or a very active patient, the rate will typically be faster. So what are some of the most common automatic tachyarrhythmias? These include, of course, the most common is sinus tachycardia, ectopic atrial tachycardia, where a single focus in the atrium is beating at a rate faster than the sinus node, junctional ectopic tachycardia, or JET, which is sometimes in Europe referred to as His bundle tachycardia, and then finally some types of ventricular tachycardia can be automatic. And again, I will remind you that when it comes to the rhythm of the heart, whatever is the fastest in the heart wins. And so when, for example, an area of myocardium with calcium channel cells are firing at a rate that's faster than the sinus node, it will control the rhythm. Let's give you an example. So this is a rhythm strip of a 14-year-old girl seen by the pediatrician who heard an irregular heartbeat and obtained this electrocardiogram and had a recent history of fainting and is not complaining of palpitations. And when we performed an echocardiogram, it demonstrated severely depressed function. And so what we're seeing here is a lot of P waves at a very fast rate, a rate of about 150 or faster. And there are some that are not conducting because they're occurring so quickly after the QRSs. And so this is an example of somebody who has ectopic atrial tachycardia, in which there is atrial ectopy from a single area of the atrium other than the sinus node. And this will commonly result in ventricular dysfunction. In fact, when scientists or researchers want to do animal studies of heart failure, one of the most typical heart failure models in dogs is to put a pacemaker in the dog and to pace the atrium at a rapid rate. That has been demonstrated to reproducibly induce heart failure within 24 to 48 hours. So that is, and this is one of the more satisfying areas of electrophysiology, because if one can treat the ectopic atrial tachycardia, the cardiomyopathy that is due to the tachycardia will almost always resolve, although sometimes takes a while. Another classic example of an automatic tachycardia is junctional ectopic tachycardia. This is a tracing from a 5-month-old following tetralogy flow repair obtained on postoperative hour 4. And in this example, we have an esophageal lead, presumably because they were not atrial leads, but this could be an atrial lead. And we can see that there is a dissociation between the A's and V's, and there are actually more ventricular complexes and atrial complexes. And whenever there are more V's than A's, you're either in heart block or in JET. And in this case, the patient was in JET. So JET is another example, and it's a very good example because I think all of you who've taken care of patients who have JET have noticed that we never cardiovert these patients. And the reason we don't cardiovert them is because cardioversion does not work in the treatment of automatic arrhythmias. This is another example of an automatic tachycardia. This is a 15-year-old who had a history of ventricular tachycardia, so-called Bell-Hassan's VT. Patient had been non-compliant with medication, came into the emergency room, and I asked the patient to do a little exercise in the emergency department, and we see that when he lifts his legs up and is doing sort of an abdominal exercise, I'm able to get his sinus rate to be slightly faster than the VT rate, and it suppresses the VT. Again, showing that when it comes to automatic arrhythmias, whatever is the fastest wins. And so when I was able to jazz up his sinus node transiently, it suppressed the ventricular tachycardia. When he put his legs back down, the VT would recur. And in this case, we ultimately just ablated this patient because of noncompliance and patient desire. Okay, now, so that's automatic arrhythmias. But the most common form of tachycardia in young people is reentry. This is the most common mechanism. And reentry represents at least 90% of supraventricular tachycardia in pediatric populations. And understanding reentry is critical in managing these patients. So what are the three major requirements of reentry? First of all, you have to have two pathways. In this little cartoon, the two pathways are on the left and right side here. You have to have two pathways that are connected proximally and distally. Next, there needs to be unidirectional block in one pathway. And that's because if they were both conducting antegrade from top to bottom, right, then you would never be able to have reentry because both pathways would have depolarized at the same time, meaning that when you try to reenter, whether from this pathway to this pathway or from this pathway to this pathway, they would both be refractory. So there has to be unidirectional block in one pathway. And finally, there needs to be a zone of slow conduction so that by the time the reentry comes back, the other pathway is no longer refractory and able to persist in tachycardia or continue tachycardia. Okay. So what are some of the general characteristics of reentry? Well, first of all, reentry can be initiated and terminated with appropriately timed premature beats. Now, why is that? So let's assume that in this little cartoon, this is the AV node, and this is a WPW accessory pathway. If both of these pathways can conduct at the exact same equal rates with equal refractory periods, any premature beat will either go down both pathways or block in both pathways. However, if you put a premature beat in that exceeds the refractory period of one pathway, but can still be conducted by the other, it will allow conduction through one pathway and not the other. However, if you don't have a zone of slow conduction, by the time the impulse comes around, this other pathway that is just blocked with that premature beat will still be refractory, which is why you need the slow zone in this loop in order to allow for the other pathway to no longer be refractory. So premature timed beats can induce or terminate tachycardia. Again, importantly, reentrant tachycardias have an abrupt onset and termination, and this can be very helpful, again, in making a diagnosis. And sometimes on an ambulatory EKG monitor like a Zio or a Holter, we can see this. And sometimes we see it on inpatient monitors. So it's always worthwhile to look at the heart rate trend in the ICU or on the floor when you're assessing any kind of arrhythmia. And then very importantly, reentrant arrhythmias can be at least temporarily terminated with DC cardioversion. Now, oftentimes people who have bad reentrant arrhythmias will go right back into tachycardia, but it is almost never the case that you won't see at least one sinus beat or at least termination of the rhythm temporarily. And again, demonstrating the importance of running the EKG when you cardiovert someone, because sometimes in real time, when you cardiovert somebody, it may seem as if the tachycardia never ended because within 3 beats, you're back in tachycardia. And usually when you shock someone, the patient jumps and it's kind of dramatic and everybody is just kind of looking up on the monitor. And as soon as the EKG settles in, you're in tachycardia, and you don't actually realize that there was in fact a period of termination. So again, I want to be clear. If someone is stable, that's a very important point. If somebody is stable in tachycardia, you should take the time to put an EKG on them and run it while you're cardioverting someone. If they're unstable, you shock and then figure it out later. But for a stable patient, it's always a good practice to run the EKG when you're cardioverting someone. Okay. Now, the most common form of reentrant tachycardia in kids is accessory pathway mediated tachycardia. This is more common in males, and the typical route for most children for the most common form of SVT is ORT, going down the AV node and then back up the accessory pathway as demonstrated in this little drawing or cartoon. And when we go any tachycardia that goes antegrade down the AV node and up an accessory pathway, we refer to it as orthodromic reentrant tachycardia, or ORT. So now you are cardiologists, so you're no longer allowed to refer to patients who are having ORT as SVT, which is what most people mean when they say that, because SVT is just a term used to denote about 7 or 8 different arrhythmias. And so When a person is going down the AV node and up the accessory pathway, we call it ORT. Some people call it AVRT or atrioventricular reentrant tachycardia, but really I think the more formal appropriate term is ORT. And this is an example of a patient who has Ebstein's anomaly and intermittent palpitations. And if we look on the right panel, we see that the patient is in sinus rhythm, and as is typical in people with Ebstein's, they have a very, very, very large P waves because they often have atrialization of their right atrium. And then we're looking at the T waves here. Now, when the patient goes into tachycardia, one of the things that's fascinating is that we now have what looks like very large T waves, right? If you compare the T waves in sinus rhythm to these T waves in tachycardia, they're quite different. And that's because these are, in fact, not T waves. These are retrograde P waves going down the AV node and then retrograde up the accessory pathway, then down the AV node, up the accessory pathway, so on and so forth. Bottom line is it's always useful when assessing patients to try to have an old EKG in sinus rhythm and a tachycardia one to use as a comparison. The peak age or occurrence for SVT or ORT is the first 2 months of age. 40% of first episodes occur this early in life. And then over the first year of life, the frequency of tachycardia episodes will decrease. And by a year of age, 2/3 of infants will no longer have clinical tachycardia. And by that, I mean that 2/3 of infants who have SVT or ORT or AVNRT in the first 2 or 3 months of life, if they're not having tachycardia by the end of the first year of life, they will no longer ever have tachycardia again. And we don't know why that is, except to say that presumably the pathways stop conducting. Interestingly, people have done esophageal testing to see if the pathways are still there. It turns out that 1/3 of babies will still have an accessory pathway conduction demonstrable by formal transesophageal testing, but in fact, 2/3 of infants will never have SVT again. And it's because of that, because of the generally positive natural history of ORT or SVT in the first year of life, that you will very, very rarely see us perform ablations in young children. There are many reasons for that, but the most important is simply that the natural history is such that the arrhythmia should get better over time. And we're always hoping that our patient will be in that positive group where they don't have any more tachycardia ever again without any intervention other than medical therapy. Now, if you go further out into a child's life, the other peaks for tachycardia, there's a small one in the ages of about 5 to 8 years of age, but clearly the majority of patients start having their tachycardia again when they hit their teen years between age about 10 and 15. And that is for those of you who are second year and third year fellows and senior imaging fellows, you know that the most common age of patients that we ablate are teenagers, and that's because that is the time when young people start having their tachycardia again, or for the first time if they're going to. And again, about 35 to 40% of patients with tachycardia as infants will recur at some time in life. And there are actually electrophysiological reasons for this. We can go over that in the future. Okay, so we should talk about SVT, about arrhythmias is complete without talking a little bit about WPW. WPW is the paradigm of orthodromic reentry. It was really, I wrote here, it's first described in 1930. It was first described by Wolf, Parkinson, and White in 1930, but there are actually reports of descriptions of WPW that go back into the mid-1800s, actually. It's an interesting history. And people who have WPW have a short PR interval. They have what appears to be bundle branch block. It's really just pre-excitation and intermittent tachycardia. And it's interesting to note that in 1930, Wolf, Parkinson, and White didn't actually understand at all why people had ORT or even were pre-excited. They just described the short PR, what they described as a bundle branch, and intermittent tachycardia as a syndrome, but they did not actually understand the mechanism. And in fact, the mechanism was not elucidated until the 1950s, like 20 years later. Now, In WPW, the pathway can conduct both retrograde and antegrade. And so when you, in this little cartoon, if you have an accessory pathway, let's, in this cartoon, we're in sinus rhythm, the impulse will go from atrium to ventricle, both through the AV node and through the accessory pathway. And so the accessory pathway is pre-exciting a portion of the ventricle that would normally only be depolarized through the bundle branch and the Purkinje fibers. And so part of the ventricle is being pre-excited before it normally would be, causing the PR interval to be shorter and the presence of the delta wave. And importantly, people who have WPW are thought to have a risk of sudden death of about 1 to 1.5 per 1,000 patient years. So this is a clinical example. This is a 15-year-old boy who had an insignificant past medical history, is seen in the emergency room with palpitations and dizziness. And what we're looking at here is a wide QRS tachycardia. It is very fast. Some of the R-to-R intervals are as fast as 300 beats per minute. And it is irregular in that the R-to-R interval is changing, and it is irregularly irregular. There's no pattern to the irregularity. There aren't, certain beats. It's not like group beating. It's kind of just going all over the place. So the patient was in the emergency department, received the appropriate therapy, and this was, in fact, the electrocardiogram afterward, demonstrating that the patient had Wolff-Parkinson-White syndrome. And what exactly was that arrhythmia? Well, in that case, the patient was in what we would call preexcited AFib. So people who have WPW are an enhanced risk for the development of atrial fibrillation, which you may recall from medical school is thought to be multiple micro-reentrant areas in the atrium. Now, in the setting of WPW, so I always say to patients, why do people who are in AFib not die usually? Well, if you don't have WPW, the AV node and bundle of His and the bundle branches can only conduct at certain rates, let's say 200 beats per minute. So your atrium may be going as fast as 300 or 400 beats per minute, but the AV node in most patients will protect the ventricle from going too fast. So patients who have AFib are at risk for rapid heartbeats. They don't like the feeling. It's a very uncomfortable feeling of a rapid heartbeat. They're at risk for the development of thrombi in their atrium, but they don't typically die acutely from the problem. However, if you have Wolff-Parkinson-White syndrome, and if your pathway happens to be a slick WPW pathway, meaning that it can conduct at rates faster than the AV node and His-Purkinje system, then what was atrial fibrillation might be conducted to the ventricle at a similar rate, resulting in ventricular fibrillation. And that is, we believe, the mechanism for sudden cardiac death in people with WPW. So it's very, very important to remember that even though ORT is by far the most common arrhythmia seen in WPW, pre-excited AFib is actually the reason that people die suddenly. Now, there are some who believe that AFib only starts if you've had ORT and that the ORT degenerates into AFib and then the AFib causes the sudden death. It's hard to know for sure, but the bottom line is that it is the ability of the pathway to conduct antegrade and how fast it can conduct in the setting of AFib that theoretically poses the risk for sudden death. So important points about WPW again is the risk of death, again, is not from SVT or ORT, but it's instead from rapidly conducted AFib, which is rare, thankfully, in infants. Very importantly, digoxin and verapamil are contraindicated in older patients who have WPW. Why is that? Let's see, does anyone know? Let me ask Christina. Christina, do you know why we would not give digoxin or verapamil generally to people who have WPW? You are muted, Christina.
Sorry. I'm not sure. Is it because they're older and there's an increased risk for clots?
Increased risk for what?
For clots.
For clots. Well, AFib in general is a higher risk for clots, but dig and verapamil do not enhance the risk for thrombosis. Now, the reason we don't give dig or verapamil is because both agents are theoretically enhance conduction through accessory pathways. So we just talked about the fact that in AFib and WPW, some people's pathways can conduct so rapidly that you could conduct the AFib to the ventricle, resulting in VFib. It's believed that digoxin and verapamil may enhance conduction across an accessory pathway, which will enhance the risk for sudden cardiac death in patients. So generally speaking, we would not give dig or verapamil to people with WPW. Now, there are some cardiologists who will use digoxin in WPW infants on the theory that it is exceedingly rare to see sudden cardiac arrest in WPW in infants, and that is based on the fact we believe that atrial fibrillation is extremely rare in infants. However, there are rare case reports of that. And so, although I would never criticize somebody for giving digoxin to a WPW baby, my personal bias, and I think that of most doctors in 2023, is to use something else. There's certainly enough other agents that we don't have to rely on digoxin, which is a very weak antiarrhythmic agent anyway. And then finally, it's always important that patients understand what the signs and symptoms of tachycardia are in their children with WPW, particularly in young infants where they're not talking and not sharing with the parent that they're feeling something. The most common would be poor feeding and sweating during feeding are typical, some of the typical examples. Now, this is a 16-year-old with palpitations and dizziness 10 years following a Fontan palliation for triatresia. And now this is a terrible tracing. Every year I do this talk and I keep forgetting to change this tracing because there's no lines on it, so you have no idea what the heart rate is. But assume for the sake of discussion that this is a rate of 120. And we talked earlier, right, that Fontan patients should not be able to get their heart rate up to 120 in sinus rhythm. So it looks as if there's a one-to-one relationship between the P wave and the QRS, and there is, but this in fact is not sinus rhythm. And in fact, you can see in lead 1 that the P wave is inverted, so it should be upright, right, in lead 1 in sinus rhythm. This is instead an example of intra-atrial reentrant tachycardia, which is a fancy way of describing atrial flutter, which we describe mostly in Fontan patients. It is a very common problem that affects between 12 to a quarter percentage of 25% of patients with repaired palliated congenital heart disease. And interestingly, the longer you are out from the palliation, the more likely it is that you will develop this arrhythmia. And so, in most medical things, if you get out a certain number of years, your risk of having a problem go down. But in fact, any patient who's had heart surgery, because they've had an atriotomy, is at theoretical risk for the development of intra-atrial reentrant tachycardia or atrial flutter. And this is a particular problem amongst Fontan patients, although the hope is that with the advent of the extracardiac Fontan, that this would be less common. And this is a study from 1997 from my friend Steve Fischberger, with on the y-axis is the probability of freedom from atrial flutter. On the x-axis is the time from the Fontan procedure. And this curve almost looks identical to the sinus node dysfunction curve, and they are related. But the point I'm trying to make here is that once you get out about 20 years from Fontan, very, very few, if any, patients have never had an episode of atrial flutter. So this study, although from 1997, has been reproduced about 10 times, and every single one has a curve, a Kaplan-Meier curve that looks very similar to this one, showing that the farther out you are from Fontan, the more likely it is that you're going to have an episode of atrial flutter. Now, again, because extracardiac Fontans are slightly newer, we don't know yet if this curve is going to be reproduced, but probably the answer is yes. And when people have intra-atrial reentrant tachycardia, it is reentry just like all the others. The difference is instead of having two native accessory pathways like an AV node and an accessory pathway, what you have is two pathways that are typically separated by a scar with an anatomical boundary like the crista terminalis in the atrium. And so you have essentially two pathways on either side of the scar, And there's typically a zone of slow conduction in this circuit that allows for tachycardia to occur. And this can be in people even who've had surgery as simple as an ASD. And this is, again, one of the most important reasons why people who had congenital heart surgery require lifelong follow-up, both by pediatric cardiology and also by adult congenital specialists, because they are at risk for these problems. And one of the theoretical reasons we like to close ASDs, for example, in the cath lab rather than surgery, is that in theory, there may be a lower risk for the development of intraatrial reentry because you haven't had to do an atriotomy to do that. That said, there are certainly examples of ASD patients who have developed IART despite having had cath-based therapy, but probably on average, the incidence is slightly lower. So again, when I'm thinking about arrhythmias, I separate them in my mind's eye between automatic and reentrant arrhythmias. And when I'm looking at an EKG of someone in a tachycardia, I'm asking myself, what I'm looking at. And the way I do it is I sort of, in my mind's eye, I work my way down from the top of the heart to the bottom of the heart. So when we're at the top of the heart, at the level of the SA node, the most common arrhythmia is an automatic arrhythmia, sinus tachycardia, but there is in fact a reentrant arrhythmia of the sinus node, which is very rare, called sinus node reentrant tachycardia. Moving down from the sinus node, at the level of the atrial muscle, we've already talked about the fact that you could have ectopic atrial tachycardia. There's also another automatic arrhythmia, sometimes referred to as multifocal atrial tachycardia. Another term for that is chaotic atrial rhythm. These are both automatic arrhythmias of the atrial muscle. And we've already talked about how you can have atrial flutter or IART or AFib at the level of the atrial muscle as a reentrant arrhythmia. So both for the SA node and the atrial muscle, you can have either automatic or reentrant arrhythmias. Moving down to the AV node His bundle area, the most common automatic arrhythmia we worry about is JET from enhanced His bundle automaticity. And the most common reentrant arrhythmia is AV nodal reentrant tachycardia, an arrhythmia which we have not discussed this morning. When we talk about rhythms that reciprocate between the atrium and the ventricle, there is no automatic equivalent of that, but certainly patients who have Wolff-Parkinson-White syndrome or who have a concealed accessory pathway, which is a pathway that can only conduct from ventricle to atrium and not also from atrium to ventricle. So it's a unidirectional retrograde accessory pathway. These can be AV reciprocating reentrant arrhythmias. And then finally, when we get to the level of the ventricles, there are both automatic and reentrant forms of ventricular tachycardia. The reentrant forms of VT are typically seen in people who have a certain scar in their ventricle. So a classic example in pediatrics would be patients who've had tetralogy of Fallot repair. There are actually specific areas that are very typical. They're called isthmuses in the RV outflow tract related to the manner in which the surgery was done and the VST patch was closed that enhance the risk for VT later in life. And then there are automatic arrhythmias, and most of the fellows have seen Barry or me try to ablate PVCs or even VT in some patients who have automatic ventricular arrhythmias. And then VF really can be, is typically an automatic arrhythmia, which is usually induced from VT. So I think at that, I'm going to stop since we're at 10 minutes of the hour and I've presented a fair bit. Does anybody have any questions about what we've talked about thus far? Okay. That's either a good or a bad sign. So just so you know, pretty much every Monday at 7 a.m. at this same channel, we will be doing EP conference. Now, I have been doing it online, mostly because the fellows seem to feel that they see the tracings better on their individual screens. So I'm happy to do it this way continuing forward. I'm also happy with doing it in the conference room. It's entirely up to you guys. You don't have to decide today. We can, play it by ear. But the other thing some of you may know is I often will post these on YouTube if you want to watch it again or review any of the concepts that we've reviewed. All right, well, I want to welcome Kataki, Christina, Ivana. I'm so excited. I want to also welcome our new second-year fellows, Molly and Maya. And it's just so wonderful to see you guys. We're all very, very excited. And even though today is kind of a short day, on Wednesday, we're going to have a little sort of donut breakfast for you guys. So sorry, it's kind of a weird week, right? Because we have a holiday tomorrow. But thank you, and very excited that you're all here. So I'll see you in sign out in just 10 minutes. Take care, guys.